베이션 6시. 짱거도 짱거. 짱거 6시. 6시. Here medial border of the pedicle here. 자, 네, 그대로.
大家可以看到，它其实把椎动膜一小部分掉。
medial border here. You can see here. Okay.
So I think there's some comments that we should speak English. So I just translate what we mentioned just now.
Okay. This is the spinal canal and the sacral sac. This is root here, axillary area. Okay, this is the medial wall and the cranial wall. I remove some more this paper, this area. Okay, covered.
So the first point of identification by Dr. Song is the typical of the rotator muscle. Second point that Dr. Zhang Wei was mentioning, and also Dr. Song, is the B point, which is the bony convergence of the C5-6 articular process. The facet joint essentially. And the third point, I think Dr. Song repeatedly emphasized, is to identify the pedicle, the medial superior margin and the lateral superior margin of the pedicle. The nerve root tends to run just above that pedicle superior medial margin, and the spinal cord medial to the superior medial margin of the pedicle. From there, we can he drew to paper thin
small curette.
I think another important landmark is the tip of the SAP, because under the tip of the SAP is the nerve root.
So we holding the tip of SAP to show the nerve root. When he used the kerrison, he bite towards the pedicle, which is the safest for the nerve root as well as for the spinal cord. He used a small size kerrison to do that. Now he's exploring the superior articular process.
1 millimeter or 2 millimeter.
Yes.
Sometimes we will choose the 130-degree kerrison punch, the no-touch technique.
Dr. Cellini raised his hand, so maybe he wants to speak, make some comments. He's our chairman of this meeting.
I think it's easy to try to touch the upper end of the pedicle.
Okay.
And then she also takes some pedicle.
You know that the epidural vein is just below ligament flavum. Okay, I don't touch epidural vein, so there is no bleeding this type. Here, pedicle is here. Pedicle is a second landmark. I will emphasize again, pedicle is landmark, second mark. Here, medial margin, cranial, lateral here. Okay, again. This root learning just here. Pedicle, lateral surface of pedicle, low pedicle is thus the true real course of the root. Okay, you send it here. This root is I don't touch, I don't remove connective tissue and vein and other tissue. That I finished. This root is full decompressed. This is also this is ligament flavum. I don't save. I save the ligament flavum. I just remove some. Okay. Okay. 셋이.
So actually, the break ligament doesn't cover into the foramen area, especially in the cervical spine. So in here, you will see some member here.
Okay.
So Dr. Song doesn't remove the member. So he try to compression first.
I will finish my cervical foraminotomy. Okay. 자, I always keep the hemorrhagic line. 자, I again emphasize the important anatomical landmark. First, bony protrusion on low margin of upper lamina. That means bony protrusion is for insertion of rotator muscle. That is the first landmark. Second is low pedicle. I always check the low pedicle after drilling compact bone. You can see here cancellous area. So cancellous medial, cancellous cranial, cancellous lateral. Finally, final goal, final point is the craniolateral aspect of a low pedicle. Okay, I removed. Okay, see you someday. Someday on I will meet you in person. Okay, see you. Okay, good luck. Bye.
OK，刚才把刀子孙的这个最后总结啊，简单说一下。他提出他第一个辨别的关键点是上位椎板的下缘，rotator 这旋转肌的浮着点是他的第一个标志点。第二个呢，他反复强调下位椎弓的上缘和内缘是他一个关键的点啊。他特别强调的是下位椎弓的皮质骨和松软骨之间界限。那么他能知道他磨的骨头呢是椎根的内侧壁啊，因为内侧壁是皮质骨，然后是中间是松软骨，他以这个为标记。来看椎根内侧壁和上壁磨出多少啊？我听了这么多。Dr. Hu, any?
Yeah, I think Dr. Chen Ming-Chen also is, of course, the expert in this. Yeah, the emphasis is the pedicle. I think there's one emphasis by Dr. Song is the pedicle to orientate where the nerve root is. It's very interesting that Dr. Song didn't take out the membrane that's surrounding the nerve root. I think maybe we can ask the rest of the panelists when they do the nerve root decompression, do you remove the membrane? I tend to remove the membrane, and in fact, I would like to see the sensory and motor branches of the nerve root before I complete my surgery.
I have the same idea, you know, if you don't remove the surrounding tissue, like maybe have some scarring, and maybe if you don't remove the member, because the member is very thin, but then maybe have some retraction, and that will cause the eccentric nerve root, then maybe congestion for the vein, and so they will also have some symptom after the surgery. So if you already done the foramiotomy, sometimes I will try to remove the membrane. Sometimes they have a little ligament will also cover, but not cover to the foramen area. So I also will use the punch to decompression in the shoulder area. So they will totally relax the eccentric nerve root. I think this is important for me. I'm not sure. How about everyone the experience for eccentric nerve root for myotomy, decompression? Maybe have a different idea.
Yeah, yes, I agree with you. Majority of time, I perform the keyhole by UBE. I always remove the member on the surface of the nerve root, then I think it can get a full decompression. But maybe Dawson consider that if we remove the member, maybe it can cause too much bleeding. But I have the small size radio frequency. I can control the bleeding. So in my majority of my case, I will remove the member on the nerve root.
No. I think if we remove the member, they will cause bleeding. That's because they have the structure problem. They already have the main congestion problem, so it will cause bleeding. But our endpoint is for relax and let the vessel doesn't have congestion in forming area. So that's very important. I think that is very important endpoint for our decompression. So I'm not sure. Maybe Dr. Song for the safety problem. So she keep the member and she only remove the bone structure. So maybe she has other opinion.
At last, I often use the probe. Use the probe to test the nerve root canal and the lateral margin of the pedicle. Then I finish the procedure. So I think the probe is very important, especially for the stenosis of the nerve root canal.
陈教授，把你们这个交流的，因为也有中国听众，用汉语简单说一说啊。我们欢迎来自台湾的陈建明教授啊，也是一个非常有名的内镜专家，也是我们老朋友啊，欢迎你。
我想是这样子，他这个大特颂的定位其实很简单，就是说你磨到这种海绵状骨的时候，你意思你已经到这个椎弓了，他试着把椎弓的上缘给找到最接近椎弓的上缘。那这些动作其实就是希望在这个椎孔这个地方能够完整的一个减压。可是这个存在的另外一个问题是，我们在这个地方会看到一层薄膜。那这个薄膜有人说是神经鞘膜的一个延伸，有人说是黄韧带的一个延伸，但是现在没有明显的告诉我们它是哪一种延伸。但是我在想，如果这个延伸你不拿掉的话，在这个粗神经根上面会有很多静脉丛。当然你移开会不会流血，这是一个问题，但是你不移开表示这静脉丛还是在充血。那我们在所谓的内视镜影像上看到它减压，并不全然代表它已经减压了。你必须考虑到我们的脊椎系统是一个动态系统，另外它是一个直立系统，那这些都会造成所谓的静脉的充血、静脉的血液回流的问题。你知道神经根的营养是靠两套系统，一套是血管系统，一套是脊髓液系统。所以当你没有看到整条神经根很好的一个膨胀、很好的一个减压，那意味着它存在着某一种狭窄，那这个狭窄就会存在着某一种症状。病人花了钱，如果没有好，这是一个很大的问题，你没有办法再做第二次手术。如果这个手术挑开这个膜是安全的，我看是魏是不是？他刚刚讲的，他就是也是习惯把这个挑开，那我也是习惯挑开，我没有看到整条 expand 非常好的。那我也曾经比较过有挑膜跟没挑膜的，那你挑了膜之后，你可以明显的发现这整条神经根是膨胀的非常好，所以它的减压才是达到我们要的效果。硬膜减压不代表减压，是神经根，这是神经鞘里面的神经减压才是我们要的减压，这是减压最终的一个想法。谢谢。
其实说的非常好。其实我觉得这个我的意外习惯一般是下位，比方颈5、6的话，会从微点的颈6的上缘这里把黄韧带这块磨出一个就是纸一样的一个情况，黄韧带支点磨开，然后实际上这层膜是黄韧带往外的一个延伸。我从黄韧带作为突破口，实际上我把黄韧带的外缘给它切开以后，实际上就能看到这个膜的开口了。然后我用一个椎板摇骨钳也好，用探钩也好，或者用这种306的这种等离子刀头把它挑起来，把它切开，就很简单的一个事情。我觉得这个膜还是有必要去切开的，如果想做一个充分减压的。
好，那个刚才 大家讨论的就是说，赵宋跟别人做 K 后的不同点啊，我认为不同点就是说，他反复强调中宫的内壁和上壁啊，我觉得你要是掏腋下的肩盘呢，这个动作是非常有意义的。如果就是像今天这个单纯做 K 后做个减压，那么中宫的内壁和上壁并没有制压，所以这个东西呢，我觉得可以商榷，可能病例不同，不一定非得这样选择。我再提出个问题，大伙儿一起讨论一下哈，就是说我们做这种 K 后手术啊，显微镜下最早开始做啊，像陈建明教授都到显微镜下来做，包括新加坡的胡教授估计也用显微镜来做 K 后手术。然后呢，我们用单孔镜做，现在用双孔镜来做，所以请你们每个人或者请大家一起讨论一下，这种 K 后手术这几种方式有什么不同啊？我简单翻译一下，就if we do the surgical PCF, we can use microscope, also we can use uniportal endoscopy or biportal endoscopy, 3 methods. What's the difference, including advantage and disadvantage for 3 methods? Microscope, uniportal, biportal. What's the difference for PCF? 中文、英文都可以讲，就是这3种手术方式做 K 后，我们大家都有过学习了。由于陈建明教授，你是神经外科医生。他肯定用显微镜也做过，那么现在您用单孔镜也做过啊，我单孔镜我也做过，那么现在我们用双孔镜，那么这几种方式怎么来选择，或者说各有什么优点和缺点，大家一起讨论一下。既然3种方式都存在，肯定各有优缺点。Professor Hu from 新加坡。Are you a neurosurgeon?
I'm an orthopedic surgeon. I did some tubular PCF, posterior cervical foraminotomy. Then I moved to uniportal and then biportal. I still do both uniportal and biportal. I stopped using tubular. For foraminotomy, if I just have a disc to remove, I would tend to do uniportal. But if they need to have a wide laminotomy, and I feel that I need to remove more bone, I prefer to do biportal. I think in the literature, biportal has 2 ways to approach the foramen. One is ipsilateral direct, one is an inclinatory foraminotomy, which Dr. David Song from South Korea is proposing it. There are advantages in each of the system, and they're all effective. Uniportal tend to dock directly onto the V point and then bypass all the soft tissue dissection, and hence it's quite efficient and it's quite fast to get to do what we want to do, like what Dr. Song do. But if a very good master in biportal, they can get this in 2-3 minutes, like Dr. Song showed us, so it really doesn't make any clinical difference.
好的，都讨论完这个问题啊。Professor Chen from Taiwan, what's your opinion about?
I think I ever have a paper published to compare with uniportal, biportal, and the microscope for the lumbar spine surgery. But you know, in the cervical, it's different from the lumbar spine because there has a spinal cord problem. So in this technique, maybe it's a no-touch technique. Maybe you cannot manipulation the spinal cord, or you can slide touch the spinal cord. So if I compare a microscope and the endoscope, that they have the water pressure problem. This is the first problem. And the second problem is most in outside the lamina, you can use the largest instrument. There is no problem. But inside the spinal canal, especially in the cervical spine, you need to use the small one. I'm not sure how about the biportal have a small one instrument. Like maybe we sometimes in uniportal, I publish use the retrocorporeal approach. So that's very small an endoscope, like inside and maybe a slight touch the spinal cord. So I think maybe the uniportal more better than biportal. This is my opinion. I'm not sure. Maybe have another opinion. Uniportal is better than the biportal because in the cervical spine you don't have a large space. You don't have a need to have a half bird. If it's a bird, small bird is enough. You don't need to have a large angulation for fasciectomy because you direct, you can sacrifice something. So uniportal, in my opinion, is better than microscope than biportal. So maybe has a biportal professor have other experience we can share. That's my opinion. Thank you.
OK, ，Thank you。陈教授和胡教授的观点大致相似，就是说做 K 后手术，他们习惯于做单通道啊。那但是呢，刚才胡教授可能讲，如果你做椎板切除，你比如说不是单纯 K 后，我个人认为可能双通道会更好一些啊。Because with the time limitation, you have to move to next section. Thank you for every colleague. Thank you 到陈、到吴、到张威、到田大胜、韩浩 and Nong Lumin. Thank you. We close this section. Move to next section. 我们下个章节马上就要开始了。下个章节我们就这样感谢胡教授和陈教授临时参与非常感谢。那我们结束张伟下个章节马上开始。
好，下一个章节我们就可能是我们这个学术会议的一个开幕式，也请几位这个法国的主委还有 Dr. Chalali 来做一下致辞相关的一些工作。好，我们要不就是艾瑞，我们进入下一个环节。
Okay, Dr. Chanali, would you please start the next session? And we can the next session will be our opening speech.
Dear colleagues, I am Dr. Maxime Chali from Grasse, south of France. I'm a French spine surgeon focused on endoscopic spine surgery. I'm the first spine surgeon performed UBE disc herniation and fusion in France. Endoscopic spine surgery will change the life of surgeons and the life of patients. I am sure that in the near future, endoscopic spine surgery will be the gold standard. I'm happy to invite you to a webinar. During this webinar, we will speak about all aspects of endoscopic spine surgery, monoportal, biportal, and destodo technique, and their application for lumbar disc herniation, stenosis, fusion, and cervical surgery. I'm sure that this webinar will give an opportunity to exchange knowledge and skills, so it's an honor for me to invite you to a webinar.
Hello everyone, I'm Dr. Zhang Wei from China. I worked at the Hangzhou Traditional Chinese Medicine Hospital. Welcome to the UBE conference in France. I hope you will have a good time at this conference, and I wish this conference a complete success. Thank you everyone.
Every day, Bond's radio frequency plasma surgical system has been being used in thousands of theater rooms of over 3,000 medical centers throughout over 60 countries around the world. Every year, over 15,000 doctors have been using Bond's radio frequency plasma surgical system to benefit millions of patients. Over 200 technical testing and millions of patient cases are done to ensure our product's safety. Over 20 rare metal materials, supplied from over 300 qualified suppliers around the world, are used in manufacturing process to ensure our product performance. The 100,000 level clean room and over 5,000 hours overall inspections are implemented to control our product quality. Rich knowledge and continual study in the technology, operational technique, surgical approach, and clinical applications make a difference when thinking about our product quality, efficiency, agility, and market competitiveness. The comprehensive clinical education platform is established by a professional team of over 20 clinical engineers to ensure an overall service system of academic, technical, and clinical aspects.
Good morning.
Every year, our market activities include over 10 Bond's masterclass, over 10 international clinical meetings, over 50 Bond's training courses, and over 100 national and regional clinical meetings. With over 3,000 doctors and medical staff involved in our technology, your health. The medical development is originated from the technology innovation and benefits social health. Bonds is committed to developing and supplying the advanced, reliable, quality, and affordable radio frequency plasma surgical system to benefit both patients and surgeons.
Good morning. I am Dr. Maxime Chali from France. It's an honor for me to see you to this webinar meeting. Due to COVID conditions, we can't do usual meeting. So I hope that this webinar platform will give us the opportunity to exchange about all aspects of endoscopic spine surgery, monoportal, biportal, or all techniques. We have a chance to have a surgeon from all parts of the world. Today from Japan, we have Dr. Sairo Keishi, Dr. Zenia Ito, Dr. Konji Sasaki, Dr. Takeaki Yashibo, and one surgeon from Vietnam, Dr. Toy Don Gok Nguyen, three surgeons from Indonesia, Dr. Yuda Batansaki, Dr. Asran Srigatan, Dr. Amataya Bad Adita. I hope I don't do mistake from names. And one surgeon from Singapore, Dr. Pang Angui. And we have some surgeons from all parts of the world. We have Dr. Ayeti from Turkey, Dr. Kaed from Spain, Dr. Fishenko from Ukraine, Dr. Wagner from Germany, Dr. Fondes from Switzerland, Dr. Marinopoulos from Greece, Dr. Coleros from Portugal, and we have some surgeons from South America, Dr. Mates Felipe Borges Lopez from Brazil, Dr. Juan Carlos Ordonel, Ecuador, and we have some local surgeons from France, Dr. Schuller, Dr. Tremlay, Dr. Zadowski, or Dr. Rue. I hope that these speakers will change and will give a very interesting opportunity to share the experience from all parts of the world. So it's time to welcome the honorary chairman of this meeting. It's Professor Lueck. He's a well-known French spine surgeon. He was former president of our spine and French Spine Society. I'm always remember that I see my first endoscopic surgery 15 years ago during my fellowship in Bordeaux with him. And he's a surgeon all time in advance for new technology and promote new technology. So you turn to speak, Professor Luec.
Activate my microphone. So thank you, Maxime, for this very nice introduction. It's a great pleasure and an honor to chair the French session of the UB with Dr. Sang-Yu Son and Dr. Zhang Wei. So UB was introduced in France recently by you, my previous fellow, and I'm very proud for that. And you are a good friend. So you showed me this technique, and I was immediately convinced, and the learning curve was very short. I must say that in the past, I was also a shoulder surgeon, so there are some similarity with the acromioplasty, which is very important for the learning curve. We are all pleased to share the experience of the French spine surgeons using different endoscopic techniques. The learning curve is always the key, and each technique has advantages. So thanks again for the webinar support by the International Society for UB and for the wonderful help of Chris Bonds and also France Rachis. And I do hope that this will be a great success. Thank you for the invitation to chair the session.
So it's now time to introduce another chairman of this meeting, Dr. Sang-Yu Son from Park Wendon Walk Hospital in South Korea. He is a legend of spine endoscopy. I tried 3 times to go to Korea, but due to COVID, all time my flight is cancelled. So it's your turn, Dr. Song.
Dear colleagues, my respectable spine surgeon around the world, nice to meet you. I'm Dr. Song from South Korea. Congratulations to the great opening of the French station of ISUBE, International Society of Unilateral Biportal Endoscopy. On behalf of ISUBE, I would like to express my warm welcome to the experts and scholars of spine field who fully have dedicated for better spine care solution. It's my great honor to participate in this meeting personally, and I'd like to especially thank Dr. Karim Maxim Chalari, Clinic D. Palaris Grasse, and Professor Jean Charles Rouet, Polyclinic, Bordeaux Nord, Aquitaine, Bordeaux University Hospital, who takes full dedicated leadership to make this great event come true. UB technique has gone through tremendous development and growth in recent years. Since I first time presented this paradigm-shifting technique to IITS Korea in 2013, I sincerely hope this time ISUBE French webinar can become a history occasion of UB expansion in European continents and the meaningful turning point for many spine surgeons to embrace innovation to realize the better patient care for spine patients in need. Now, after a while, many days of settling down and winning over against the pandemic issues, I'm sure that we are ready to dust off and get ready to go forward to do what we have to do in our field. I will always keep my finger crossed for all of my colleagues, spine surgeon prosper. Last but not least, I especially thank Endospine Max and Bonds for their hard work supporting us to accomplish the lofty mission of UB technique expansion to more spine surgeons around the world. Sincerely, hope to see you all in person in near future and always hope for the best for you and your family. Good luck.
So now it's time to invite the third reconciling guest for this meeting. It's Dr. Zhang from Hangzhou Hospital of Traditional Chinese Medicine. He's a leader of UBE in China, and he learned me the basics of UBE surgery. And I can remember that he was all time support me when I began my practice. So it's your turn, Dr. Zhang.
Thank you for invitation. Dear colleague, I'm Zhang Wei from China. Welcome to attend ISUBE 2022 webinar from station today. It's a great time for the worldwide surgeons to gather together to share their knowledge about a minimal invasive technique of UBE. How to achieve the best outcomes of the minimal invasive spinal surgery technique is the most focusing issue among surgeons. Thanks for the development of the spinal techniques, there are more and more options in minimal invasive technique, include the UBE technique, uniportal endoscopy, etc. On behalf of the ISUBE, I would like to thank Bounce Medical Company for solely sponsor ISUBE events to contribute to UBE development. This morning in China and South Korea, we have presented 3 UBE surgical cases by me and by my teacher, UBE Master Dr. Sun. Now we are very happy to have this opportunity to present UBE technique lectures by listening to the worldwide UBE surgeons. I hope all colleagues enjoy the time together and can reach a consensus and work tight to promote the innovation and the development of the UBE technique so as to benefit the patients. Finally, I wish this conference a full success. Thank you, everyone.